neurology, this is a disorder. In some time in your life, you have already noticed that some person in the market or in the street suddenly got severe convulsion. Firstly, there is a tonic phase and all the muscles become taut like this, then started convulsing. And after that, a few seconds of convulsion, that person becomes very quiet. That you have noticed in many places. This is a typical grand mal or tonic-clonic convulsions. So, to discuss it elaborately, it is a very common problem in your will be in your practice. So, carefully you listen these things. Next slide. So, it is a definition of seizure. Seizure is a spontaneous, episodic, synchronous. Each word is important. It is spontaneous, not provoked by anything. It is spontaneous. It is episodic, not occurring all the time. Occurs after few hours, few days, few years. That may come. So it is episodic. It is synchronous, not bizarre. Not bizarre. Synchronous means a synchronous conversion. Not that sometimes some involuntary movements may be bizarre movement like chorea, athetosis. That are also involuntary movements in your neurology. If we get a time, we will have a separate class on this chorea athetosis. That is a bizarre movement. There is no synchrony in this. But this is a synchronous movement. And there is excessive neural activity of the brain. So in the brain, there is a cortical cells. So there is a focus in the cortical cell from where the electrical activity spreads and the whole cortical cells sudden electrical discharges that produces the convulsion. So it is a spontaneous, episodic, synchronous, excessive neural activity of the brain. This is seizure. But seizure and epilepsy is not synonymous. A single onset, the first onset, we don't know anything, we can call it a seizure. But when it is a repeated onset, means there is maybe some underlying cause is there which is causing this motor activity. We call it a seizure, call it epilepsy. So a seizure is a single episode, first come to us, we call it a seizure, but when it becomes repeatedly occurring, we call it a epilepsy. Epilepsy is a clinical phenomena that occurs in many disorders, so there is an underlying cause. That's why the single seizure do not stop it, it occurring in repeated episodes. So we call it a epilepsy. Underlying etiology characterized by 2 or more unprovoked seizures. So when up to 2 or more, this single seizure, that's why I am telling, that single seizure you cannot call it a epilepsy. When it occurs 2 or more and the underlying cause gradually reveals the underlying cause, then you call it a epilepsy. So for example, suppose a patient in a diabetic patient is getting insulin, probably he has taken insulin more, or after insulin he has not taken food, patient will land up in hypoglycemia in the next day. So that hypoglycemia called a seizure episode. But that seizure we cannot call it epilepsy. That is a single episode occurs due to hypoglycemia. So this is a seizure. An epilepsy is a recurrent episodes of the same thing having the underlying cause where that will occur. But suppose a patient had a cerebral stroke, and after that cerebral stroke, patient has a fibrotic foci in the cortical cell. That cortical cell has become a focus that is spreading its electrical activity repeatedly in repeated episodes. So that's why we call it an epileptic. So this seizures we can divide it into a focal seizure and generalized seizure. The basic difference between focal seizure and generalized seizure is the focal seizure, the episode is in the single hemisphere, not both right and left hemisphere at a time. It is only on either in the right or in the left hemisphere. We call, and naturally if it is confined to a one hemisphere, then the seizure episode will be very localized, not a widespread seizure. So we call it a focal seizure. It arises from the one cerebral hemisphere at the onset, right? At the onset, but at the onset it is a focal, but it may be secondarily generalized. Suppose a patient, suppose there is a focal seizure comes with this. but that may be, we'll come to that, is Jacksonian march, and there will be generalized afterwards, but it always starts with a focal seizure, single limb or both the limb, arises from usually in the single side, it's a single limb. Then the other limb and the other hemisphere also may be involved secondarily, but onset is always in the cerebral, one cerebral hemisphere at the onset, and with intact or impaired awareness. This is important. Focal seizure may be, any seizure may be with intact, you'll have to differentiate it in different way in seizure, but it is a motor or non-motor, that is very basic difference. There will be motor symptoms, there will be non-motor symptoms. Motor symptoms, voluntary activities, there is a motor symptoms, and the no voluntary activity, suppose a sensory symptoms like a sense of hallucination, patient gets a sense of smell which is not there. Suppose they get a sweet smell or get a pungent smell, bad smell, and then that also may be epileptic attack. So epileptic attack may be motor attack like a voluntary movement, maybe non-motor sensory attack, maybe autonomic attack. Autonomic attack, there is an attack of sweating, sudden palpitation, sudden rise of blood pressure, or maybe sudden emotional burst, sudden crying, sudden laughing. A patient may not be aware of that. Yeah, I am laughing, I am crying. That may be a episode of seizure. So a seizure may be focal, it may be generalized, it may be motor, it may be non-motor, or non-motor. Non-motor may be sensory or may be autonomic. So like this, all these things, concepts will come into differentiating seizures. Like focal seizure, then it may be motor. I have told you Jacksonian march. That is, it may be post-epileptic motor. Jacksonian march, I have told you, suppose a patient started seizure like this, just a single finger movement. Then the whole hand starts movement gradually. Then one body starts movement like this. So it is called Jacksonian march. It is marching from very peripheral part to the proximal part. It is called Jacksonian march. It is very typical of focal seizure, focal motor seizure. So maybe post-epileptic motor deficit called, and this seizure is also sometimes associated with a post-epileptic Todd's paralysis. Todd's paralysis means after that seizure happened, suppose it happens up to 30 to 45 seconds, then suddenly the limb becomes paralyzed, no motor activity in that limb, and it may persist up to 24 hours. That's Todd's paralysis. In that phase, if the patient comes to you, you have not seen the convulsion, you have seen only the paralytic movement, flaccid paralysis of the limb, then it may be mimics with the CVA. You may think it is a case of cerebrovascular accident. So there are some cerebrovascular accident mimics like TIA, transient ischemic attack, that recover with that, by definition, the total neurological deficit that develops will totally recover within 24 hours. Another mimics is Todd's palsy, that may present as a cerebrovascular accident like that, paralysis of the one limb, but that will also completely recover within 24 hours like TIA. We also call it a Todd's palsy, like that. Then these Todd's palsy do not occur in generalized seizure usually. It is a features of, it is one of your favorite MCQ. The Todd's palsy occurs only in focal seizure, not in generalized seizure. Anyway. Then non-motor symptoms. I have already told you, the non-motor means there is no voluntary, there is no motor activity, but there are other sensory activities like aura. Aura may be present followed by a, this non-motor activity usually preceded by a aura. Aura, I have told you, aura means there is some feeling something that will happen. It is not happening, the discharge is not there from the cortical cells, but patient can feel that it will happen very shortly. That is aura. Maybe this aura may be followed by a sense of this. These are the symptoms of this non-motor symptom. Paresthesia. Anesthesia means total loss of sensation. And paresthesia is a positive sensory finding. Patient feels that something is going there. Some bugs, patient will tell, some insect is going through my hand. You cannot see it. Patient cannot see it, but patient see, no doctors, I have that feelings every day. Some bugs are moving through my hands. See, you cannot. So this is a paresthesia, abnormal sensations in the positive sensory finding. Paresthesia is a positive sensory finding. Even anesthesia is a negative sensory finding. But this paresthesia is a positive sensory. Patient feels something. Anesthesia means patient do not feel something. Like this is called paresthesia. So it may be a sense of paresthesia, maybe visual hallucination, which is not there. Patient can see it. That is called visual hallucination. Suppose the rope is hanging from the roof. The patients see it as a snake. It is very difficult to make them understand during that time. During that time, patient will always know there is a snake. Everybody is saying there is a rope hanging from the this roof, but the patient will tell, no, this is a snake. So these things is a visual hallucination. Sometimes may not be, even the rope is not there, nothing is there, patient sees something, visual hallucinations. And also there may be odor hallucinations. I have already told you, some smell is not there. Patient হঠাৎ মনে হলো আমি বাগানের মধ্যে ভীষণ ভালো ফুলের গন্ধ পাচ্ছি. That may be epileptic attack, nothing. So it may be a good smell, maybe a pungent smell, like that. So it's an odor hallucination. And temporal lobe or déjà vu phenomena. Déjà vu phenomena, you know, déjà vu these things which is not there, patient feels these things. Either see or smell or have feeling of that. This is called déjà vu phenomena. And I have told you this for maybe motor, maybe non-motor, even maybe autonomic also. There is no motor activity, there is no sensory activity, but there is only autonomic activity, particularly it occurs in temporal lobe epilepsy. That is maybe sudden tachycardia, sudden BP rise, salivation. Am I obstructing the screen? No. Am I obstructing the screen? No. দেখতে পাচ্ছ সবাই তো? Anyway, so there may be temporal lobe epilepsy, there may be sudden onset tachycardia, maybe rise of blood pressure, maybe excessive salivation, maybe excessive sweating and emotional act like sudden crying, sudden laughing, like this is emotional activity. So all this comes under the focal seizure. Previously this it was also called partial seizure, but nowadays we use the term focal seizure. And that partial seizure previously was differentiated into simple partial and complex partial. Simple partial means the patient is aware of the whole period. We called it a simple partial, and we are in the old books you will get there is a simple partial and complex partial. This partial means focal. Then simple partial means patient is the whole thing goes in aware of the patient. Patient do not lose the awareness. But complex partial means patient lose the awareness. The patient do not have the idea what had happened, that event. That is a loss of awareness. So previously there was a definition. Some old books you will get the simple partial, complex partial. But today's there is a should be defined as a focal. This focal motor, focal non-motor, focal sensory. Like that you divide. Then it comes a generalized seizure. Generalized seizure, you know, I have told you that generalized seizure means both the hemisphere is affected. It is not event of the single hemisphere. So it is generalized seizure. So generalized at onset, maybe motor. Again, this may be motor and non-motor. What are the motor? Generalized motor. Generalized motor means there is a tonic-clonic seizure. A typical tonic-clonic seizure. That is also called a grand mal epilepsy. Typical is a tonic phase and a clonic phase. And it may be non-motor or absence seizure. Absence seizure very common in children, maybe secondary, maybe this non-motor symptom absence seizure may be sensory, may be autonomic, may be emotional. Similarly, for that was in focal seizure, these non-motor symptoms may be absence, may be sensory, autonomic and emotional. It is not localized, it is generalized symptoms. Absence seizure. Next slide you will see the generalized onset seizure. We are describing it little elaborately. That typical absence seizure is a non-motor petit non-motor. Previously it was called petit mal seizure. It is very common in children. Very interesting finding occurs. Suppose a mother come to you with his child that my child is very inattentive while he is reading books. He gives a staring look through the window, doesn't look at his book and remains continues staring about 3-4 minutes. In that period, if I call him, he cannot respond. That is the absence seizure. This is not an inattentiveness to the study. Patient, that child has the absence seizure. He gives a staring look through the window to anything, and that child is not also aware of that. What I am doing, but the mother is is beating him and come to you. The patient is not. My child is not reading. while reading he is inattentive. So this thing is very important for children. They comes with this very peculiar symptoms. So this is typical absence seizure is non-motor. Previously it was called petit mal. This is a sudden brief lapse of consciousness without loss of postural control. So I have told you it is a loss of consciousness. Even the child is not aware of that. What have happened? Why his mother is beating him? She has no idea about that. But the postural control is there. Postural control. The child was sitting in a chair. He is still sitting in a chair. So there is a loss of postural control. There is no postictal confusion. When this recovers from it, he has no postictal confusion. After that, some symptoms like that, after he has completely recovered and has no idea about what happened for last 3-4 minutes. So this is the confusion may be associated with unilateral bilateral motor activity. These symptoms sometimes may have a minor motor activity, not major, like lip smacking, like some hand movement, maybe small motor movement may be associated with it. Onset is usually children within 4 to 10 years. I have already told you it is very common in children. Maybe staring out that I have told you may occur many times in a day. It may occur many times in a day. For this MCQ answer I have given this line. EEG may show a typical 3 Hz and spike wave pattern. This is some MCQ comes like that. Petit mal seizure or the absence seizure is associated with typical EEG finding. That is a very typical EEG finding, which is called 3 Hz spike and wave pattern. Below it is, you see here you see the spike and Hz pattern. Below the picture is typical of this 3 Hz spike and wave pattern. That is typically EEG occurs in typical absence seizure in children. And generalized tonic-clonic seizure, previously it was called grand mal epilepsy. It is also have a tonic and clonic phase, may involve respiratory system causing epileptic cry. That is due to the patient, there may be laryngeal, the whole body is in a spasm. So there may be laryngeal spasm and the air coming through this spastic larynx may cause symptoms like is called cry. So it is called a epileptic cry. Patient may happen that patient is crying like that. It may appear like that. It may be associated with the biting of a tongue. We have many. We have already have the experience. I have heard the stories. Some of your neighbors that this patient had the epilepsy and had a tongue bite. So it is a biting of the tongue. There will be laryngeal spasm. I have already told you, and also maybe aspiration. This may be a catastrophic for the patient. Patient during this phase, patient may have aspiration. Patient may have traumatic episode. Suppose the patient was swimming, and that episode of epilepsy occurred at that time. The patient will drown. Will be drowned. There will be drowned. So this may occur. Suppose the patient is cycling, and this convulsion comes. Patient may fall. That may cause a head injury or even a major road traffic accident may occur as a result of that. So several catastrophes can occur in these patients. You have to advise the patients when you have this epilepsy, grand mal epilepsy. You have to advise the patients. Don't do these activities. Okay, don't cycle, don't swim, or don't sit on the side of the auto. You may lose your grip and you may fall. So these things are these activities where he may fall in danger. They should avoid these activities. Anyway, so these are the part of the management also. So involuntary, this patient may have a aspiration that period. In that period, all the patient may have involuntary passage of urine and stool during that period. This involuntary passage of stool and urine and this tongue bite, these are very hard proof for that patient had these convulsions, because there are several other other things are there in the clinic in your medicine. But suppose the patient has a psychogenic convulsion. Patient do not have this anything in the pathogenic psychogenic convulsions. In that case, patient will not have these things. Or sometimes we will have to differentiate it from syncope. Syncope, there is a sudden loss of consciousness, LOC, loss of consciousness. So sudden loss of consciousness from psychogenic episodes, or maybe some seizure mimics, epileptic mimics. They behave like epilepsy, but often there is difficult to diagnose. The patient has had a syncope or a seizure, difficult, or is a psychological seizure, or the patient definitely has some organic cause of this seizure. Sometimes it is difficult to differentiate, but these things, this presence of this tongue bite, these autonomic symptoms like your voluntary passage of urine and stool, that will give the clue that the patient had a true seizure. May be associated with postictal confusion, and that after the episode seizure, like that an absent seizure we have already, there is no residual thing. The moment the patient recover from the seizure, he or she will be all right. But here not that. After that episode of seizure, patient has a state of confusions. Sometimes patient becomes very drowsy for the whole day, or 2 hours, 3 hours, like that, and maybe associated with lethargy and amnesia, like that. Now, very important cause of seizure. So far we were discussing at the there is no secondary cause, no cause found, at least no obvious cause found. There may be some EEG changes, but we don't get anything in MRI or CT scan. We do not get anything. Only EEG changes if it is done during seizure. We will see the EEG changes, but there is a structural deformities or defect found in the brain. But here are the secondary causes. These are almost these will it will cover almost many cases of your seizure. Focal seizure, and there is primary seizure. This is secondary seizure. We will face it in minutes. So it's a disease or conditions. To remember this, if you see these causes, this can be remembered like this: VITAMIN, vitamin. And if you can remember this DO, other you can remember like this. So for convenience of your to remember these conditions, I can we have classified is like vascular cause. What are the vascular can cause seizure? You already know that acute ischemic stroke. Patient come with acute ischemic stroke, may comes with a episode of seizure. Intracerebral hemorrhage. This is also a part of the. This is also in the domain of ischemic stroke, but it is hemorrhagic stroke. And subarachnoid hemorrhage. These are all can present with a episode of seizure. And PRES. PRES I have already told you what is this, a posterior reversible encephalopathy syndrome. These all can present with a seizure. Is under vascular cause. Then cause infectious cause like meningoencephalitis, brain abscess. In our previous class, we have already taught about meningitis, brain abscess, and space of occupying lesions. They can give rise to seizure. Traumatic cause. There is epidural and subdural hemorrhage. That also we discussed in our previous class. There is several layers of meninges. There is below the dura, there is subdura, and below the and above the dura is epidura. So subdural and epidural space may be the site of hemorrhage, particularly in trauma. And autoimmune causes, very important cause is SLE. Your systemic lupus erythematosus has unique neurological features, and even before they are coming with your arthritis, malar flash, you know what happens in SLE. There is malar flash, there is arthropathy, arthritis, there is renal impairment, kidney disease, but they may present with a episode of convulsions. Patient comes with convulsion, we go to for investigation, we found there is a case of SLE. That may also happen. So that's why this may be SLE may present with a convulsion. And paraneoplastic syndrome. So now what is paraneoplastic syndrome? If there is a neoplasia or malignancy in anywhere in the body, there is some immunological phenomena occurs due to this the presence of this neurology, SOL or these neoplastic lesions, or sometimes the neoplastic lesion, particular lesion produces some hormones that will cause suppose there's the bronchogenic carcinoma. That bronchogenic carcinomatous lesion can cause parathyroid hormone. That's called hyperparathyroidism. So this because they are cancer cells, they are abnormal cells, they can behave as endocrine cells, anything they can produce. There are interesting paraneoplastic syndromes are there. They are not the symptoms of the cancer itself, but due to the immunological phenomena to that cancers or the hormones produced by the cancer cells itself. That causes some paraneoplastic syndromes. So this may cause as a convulsion. So not as a direct invasion of the brain. No, there is no direct invasion of the brain by the malignant cell, but as a phenomena of paraneoplastic symptom, they may have these convulsions. Next is the idiopathic epilepsy, neoplastic There is a glioblastoma, meningioma, and metastatic. Here there is a SOL, there is a tumor in the brain, like glioblastoma, meningioma, and metastatic. Means there is a cancer somewhere else, and the cancer deposit spread through the hematogenous spread. It goes to the this cortical cells, and it produces a focus that causes convulsion. So many drugs are there that can produce convulsions, like opioids, like tricyclic antidepressants, like amphetamines, lithium, drug withdrawal, sometimes called drug withdrawal, particularly alcohol withdrawal, may cause convulsion. Other causes like degenerative disease, like Alzheimer's disease, demyelinating cause like multiple sclerosis and preeclampsia. These are if you can go through these metabolic causes, therefore very interesting causes are there.
What is phobia?
There is hypoglycemia. I have already
Layers
told you.
of retina,
There is a certain fall of blood sugar,
optic
hypoglycemia,
chiasma,
and alcohol with
this
thiamine
portion
deficiency,
related to the brain and the vision.
hyponatremia, sodium,
The
less
rest,
sodium,
again, very
hypomagnesemia,
important.
hypocalcemia,
The
uremia,
ocular
hepatic
muscles,
encephalopathy. These metabolic causes are very important, and when
Blood supply
you will face
of these muscles.
all these conditions of the metabolic
And
causes in your life, the patient presenting
they
with
are
convulsions like
injured,
hyponatremia,
what will be
hypocalcemia,
the result?
hypomagnesemia. From these causes, the
You
interesting
go by
questions
part by
arise.
part,
Sometimes
fragmented.
this is asked in your exam. Yeah,
And
suppose an alcoholic patient come in the emergency room with a episode of seizure, convulsions. What may be the causes? Yes, suppose the patient has a mild jaundice, alcoholic liver disease. That's why the mild jaundice, and the patient is non-alcoholic, mild jaundice, presenting with convulsion in the emergency. What are the causes? You can find many causes from here. Patient may have a thiamine deficiency. Because he is alcoholic, there is thiamine deficiency, and it is a recoverable cause. You can, if you infuse thiamine, injection of thiamine, patient will recover. So, thiamine deficiency, alcohol, and there is drug withdrawal. Alcohol withdrawal may cause convulsion. So, these are the causes. Actually, thiamine deficiency, or maybe alcohol withdrawal may be causes, or that patient may fall in this influence of alcohol, that the patient may fall in some hard surface and had got the head trauma that can have subdural hematoma. So patient পড়ে গেছে আস্তে আস্তে ঠিক নেই নর্দমে পড়ে গেছে মাথা লেগে গেছে গিয়ে subdural hematoma হয়ে গেছে that patient may convulsions. What are the possibilities you have to keep in mind in your emergency room when you are in emergency duty? Patient is alcoholic and under the influence of alcohol, mild jaundice has come with convulsions. So these are the causes. Thiamine deficiency, there may be hepatic encephalopathy, second cause, third cause is subdural hematoma, fourth cause is your alcohol withdrawal. So these are, and definitely hepatic encephalopathy. So these 4-5 are causes. The causes are coming in this chart also. You can find these 5 causes of these conditions. Alcoholic patient presenting with convulsion. Now come to these anti-epileptic drugs. There are several anti-epileptic drugs. We can classify it in these 5 groups. We have classified in these 5 groups. So one is sodium channel blockers, decreases glutamine release in postsynaptic end. You know that there are neurotransmitters in the synapse. Usually the glutamate is a has a stimulatory effect. It also stimulates the nerve cells, glutamate. And GABA is an inhibitory effect, usually in the neurological synapses. GABA usually have an inhibitory effect. And dopamine, that may be stimulatory, may be inhibitory, depending on the receptor. So grossly, there are many neurotransmitters. Grossly, you can remember like this: glutamate is this is a stimulatory, GABA is inhibitory, and dopamine may be stimulatory, may be inhibitory. Because many drugs in neurology, not here, in your Parkinsonism, in your involuntary movements, choreoathetosis, many drugs are depending on these neurotransmitters. So you'll have to remember these basic three neurotransmitters. So sodium channel blockers, what they cause, ultimately they decrease the glutamate release. That will, if the glutamate release is decreased, naturally it will be inhibited. So that epileptic focus will be inhibited. Examples are valproate, sodium valproate, you know. They are phenytoin, the topiramate, lamotrigine, and carbamazepine. These are the drugs which access to the sodium channel. Then next group of drugs comes are calcium channel blockers. Like these acts as a SB2A receptor. SB2A receptor is also a receptor inside. It is intracellular receptor. Intracellular receptor calcium channel. Yes, see this receptor there. They also same. They decrease the glutamate release, but in a different receptor. The examples are gabapentin, ethosuximide, ethosuximide. This ethosuximide is a drug of choice in absence seizure. I have already described what is absence seizure in a child is. That the ethosuximide is a drug of choice in that this absence seizure. There are separate SB2A protein inhibitors. SB2A I have told you is a receptor, calcium channel receptor, intracellular calcium channel receptor. So SB2A protein inhibitors are levetiracetam. Very commonly nowadays we are using levetiracetam as a first line drug even levetiracetam, and oral preparation is available. Very almost a non-toxic drug. That's why we are using levetiracetam nowadays. Very much we are using levetiracetam. So SB2 is a SB2A protein inhibitor. Next fourth group comes is NMDA receptor blockers. NMDA receptor blockers. They blocks the glutamine. They blocks the glutamine to bind to postsynaptic receptors like ketamine, and GABA receptor agonist like benzodiazepines like diazepam, lorazepam, metazolam, phenobarbital, and propofol. GABA receptor antagonist. These are the almost the few of my, so not covering all the drugs, but most common drugs we are using in our regular practice. One important question is here: all drugs are very almost very toxic. Like sodium valproate, they are very hepatotoxic. Phenytoin, they are very neurotoxic drug. I will come to that in this slide. What the complications is. There's sodium valproate you cannot use in pregnancy. Even phenytoin should be avoided in pregnancy because it's called as fetal hydantoin syndrome. There is one syndrome called fetal hydantoin syndrome, which causes a microcephaly, small head, and the baby may born with cerebral palsy, like that. So phenytoin is also very not a good drug in pregnancy. The most favored drug in pregnancy are this lamotrigine, or you can use also levetiracetam. Levetiracetam and lamotrigine you can use in pregnancy. All other drugs are to be avoided in pregnancy. So what is status epilepticus? Status epilepticus is the condition where there is a neurological emergency, where the seizure are lasting more than 5 minutes. Recurrent seizures without recovering of consciousness between episodes of treatment. So there is a recurrent seizure, there is a recovery between the two episodes. One seizure episode, then patient goes into second seizure episode, third seizure episode, going on. So this is occurring for more than 5 minutes is very too much time. Anyway, if it is occurring for more than 5 minutes, we call it a status epilepticus. It is an emergency because in that period, it is a long period. Patient may have got aspiration, may die. Laryngospasm can kill the patient. So it is a very serious conditions. You can have to save the life of the patient. In that case, one episode of seizure may automatically recover. If you don't give anything, patient may recover from seizure. But here there is no recovery. Repeatedly there is seizure. We call it a status epilepticus. So management of status, this also comes as a short note. Status epilepticus causes the same epileptic causes they can goes into status epilepticus. The management is very important. ABC, there is a respiration of airway, there is breathing, and there is circulations, and check blood sugar immediately because hypoglycemia, it is an important immediate recoverable and very promising for your treatment. The patient will recover automatically. Immediately, patient immediately if you give a dextrose injection in a hypoglycemia patients. It is very common phenomenon in your ward practice. So many patients are diabetic nowadays. So many diabetic patients are getting insulin. If they go do overdose insulin or they don't take food after taking insulin, in the next day they will end up in hypoglycemia and attend the emergency in a convulsive stage. If you give a 25% or 50% dextrose, patient recovers immediately. Patient actually presents in unconscious state. Patient recovers immediately and is very promising treatment. So these patients, and I have already told you if the patient is alcoholic, and if there is a history of alcoholism, there may be a thiamine deficiency may give rise to these convulsions. To give thiamine infusion immediately. This is also under emergency treatment like dextrose. Thiamine also will recover the patients if a patient is alcoholic and thiamine deficient. Now, if it is a pregnancy, you know that pregnancy there is eclampsia, there is a pregnancy convulsions. We call it eclampsia. No, in previous class you had a gynae class. So in that class you will learn more about eclampsia and preeclampsia. That patient is also present in convulsion. In that the treatment is IV magnesium, 4 to 6 gram. So these are the emergencies. That eclampsia patient may present with status epilepticus. The patient is repeatedly going to epilepsy. So in that case, you will have to give magnesium as an anti-epileptic drugs. Benzodiazepines, lorazepam 4 mg IV or midazolam 10 lorazepam is firstly preferred because of longer duration of action. This lorazepam 4 mg IV or you can give midazolam. Start anti-epileptic drugs loading dose, but this status epilepticus you cannot just give a diazepam or a lorazepam. Patients get relief of the symptoms, you cannot leave them. You have to continue the drug because patient had the history of repeated convulsions. Patient may go into convulsion when they after this effect of the drugs went off. So we will have to give a loading dose of phenytoin. We will come to the dose next slide. Start a anti-epileptic drugs loading dose like phenytoin, levetiracetam or sodium valproate. If I give the first you give this anti-epileptic drugs, then give us a loading dose, then give a maintenance dose of that drugs. So loading dose of this in convulsion still, then sometimes it is a very refractory cases of convulsions, not relieved with all these measures, then we have to go to incubate the patient to save the life. You know, I have told you there is a chance of aspiration, chance of laryngeal spasm. So intubation will save their life. Intubate the patient and start IV propofol or IV midazolam or IV ketamine. So IV propofol and IV ketamine or in IV phenobarbital is very commonly used in refractory convulsions. Phenobarbital and continue maintenance dose of anti-epileptic drugs. I will come to the maintenance dose. Next slide. And also sometimes they call it a ketogenic diet. Some ketogenic diet, they also prevents the recurrence of these convulsions. The ketogenic diet. So I have already discussed about this. The epileptic mimics. What mimics epilepsy? Like you know, I have already introduced syncope. Syncope is a sudden loss of consciousness. There is this tonic-clonic phase. This post-ictal confusion, tongue biting, urine and stool, involuntary passage of urine and stool. These are not things not in syncope. Syncope had a sudden loss of consciousness, brief period loss of consciousness, patient recovers automatically. Usually these things also, but sometimes there may be. If a patient had a cardiac syncope or any syncope due to hypotension, sudden hypotension or loss, that patient may have a involuntary passage of urine and stool in that during that period. Patient may have a brief motor convulsions during that period of syncope. So sometimes it is not that way watershed compartment between the syncope and seizure. They have many symptoms sharing with each of them. So this syncope and seizure both can maybe it produces a confusion. The patient has a history of syncope and the patient had an involuntary passage of urine in that period. So you will be in a confusion whether it is a syncope or seizure because the eyewitness they can only tell. You are not the eyewitness. You have seen the patient after the episode. So it is very important to document the things from the eyewitness. So what you have seen, if it is available. Sometimes it is not available. So in that case there is a confusion. How to differentiate? That's why there is a presence of aura. If there is a presence of aura, whether this prodromal symptoms, patient feels that I will have this. If this presence, this goes in favor of your epilepsy. And there is a prodromal symptoms and typical tonic-clonic phase, this goes in favor of your seizure, not syncope. A stage of confusion or atonia after the episode, it goes in favor of seizure, not syncope. And incontinence of urine and stool usually goes in favor of syncope, but can occur, usually if it goes in favor of seizure, but can occur in syncope also. Tongue biting, very rare in syncope, but can occur. Eye opening is a very important phenomenon. During seizure episode, eye always there is a open eyes. Eyes are always remain open, and there is a conjugate deviation of the eye to the opposite side. Suppose the focus is in the left, the eye is usually conjugate deviation both the eyes there is a conjugate deviation to the opposite side usually. If this is present, the eye opening eyes and conjugate deviation, that will differentiate it from syncope and also from psychogenic seizure. Many times you will get a female patient coming with psychogenic seizure. To differentiate, always ask these questions: eye was open during that period episode or not? If the eye was open and conjugate deviation was there, it is definitely goes in favor of your true seizure, not psychogenic seizure. So this is a fast onset unprovoked seizure, single onset. Don't start anticonvulsant. There is one question is postgraduate students, not you. The management of fast onset seizure. That is not your question. Postgraduate question. So management of fast onset seizure. You have to be very choosy. The fast onset seizure may be due to hypoglycemia. You should not give anticonvulsant drug because patient do not have hypoglycemia later in his life, in the rest of his life. So you should not start anticonvulsant just seeing a convulsion. So fast onset of convulsion, you just try to investigate more, then you treat. Investigate more, then you treat, because why that convulsion occurs. Recoverable cause, hypoglycemia, I have told you, thiamine deficiency, so many these are electrolyte imbalance like hyponatremia, hypoglycemia, hypocalcemia, so many important causes are there which may not the patient had in the rest of his life. You should not start anticonvulsant to this. So it is important that you have to be choosy when it is a first episode, but from second episode and onwards you will have to keep. So anyway, the fast onset seizure, don't start anticonvulsant in the fast onset seizure. Try to know the cause of it, whether it is hypoglycemia or hyponatremia. Try to know the cause of it. Look at the correctable cause like hypoglycemia, metabolic cause like hyponatremia, hypocalcemia, magnesemia, hepatic encephalopathy, uremic encephalopathy, several respiratory and even the type 2 respiratory failure, carbon dioxide narcosis can cause convulsion, and severe acidosis and alkalosis can also cause convulsion. Anticonvulsant where to be used? It is more than one unprovoked seizure or risk factor of seizure is present. Hypoglycemia, I have told you how to treat. Give a 50% dextrose, or if it is available, 25% dextrose you can give if it is available in the world. And alcoholic and hepatic disorder, we give a injection thiamine, 100 milligram infusions. Active convulsions, we give a injection lorazepam. Doses are important. Try to remember the doses. This is 4 milligram IV in 2 minutes. 2 minutes means it has to be given slowly, not in short. It is to be given slowly, because if you give in short, that can cause respiratory depression. That's why it will be given in some period during 2 minutes. And this lorazepam I have told you, it is a longer duration of action, 12 to 24 hours. Diazepam, if it is not available, lorazepam, we can give diazepam at the acute episode. It is only given 10 milligram in 2 minutes. Duration is less than 1 hour. Or you give injection phenytoin. Loading dose is 15 to 20 milligram per kg, given slowly, and 50 milligram per minute. This is a rate of infusion. They were giving the loading dose. And phenytoin you can start usually given and then continue this. If it is a status epilepticus or there is recoverable, the recurrent causes are evident, then you should start. You give a maintenance dose of 3 to 5 milligram per kg per day, 300 milligram per day. Therapeutic level. It is important to know the therapeutic level of phenytoin, because the phenytoin have many neurotoxicity. I told you, like nystagmus, like that, and these are involuntary movements. So in that case, if you are getting the patient is getting phenytoin, and if you comes with this nystagmus, then you have to determine what is the blood level, what is the serum level of phenytoin. Normally it is 10 to 20 microgram per ml, but these toxicities are there. That's why you are very strict about the serum level of phenytoin, because there are various toxicities like arrhythmia, ataxia, nystagmus, diplopia, and acute and the phenytoin causes gingival hyperplasia, gum hyperplasia. It can cause rash. It is causing folate deficiency, osteomalacia are the long-term complications of phenytoin. So that's why the therapeutic level in the serum is important. It is available also in the lab. They can give you the result of the serum phenytoin level. You can do it. It is available in almost all labs. Valproate loading dose is 25 to 45 milligram per kg at the rate of 200 to 500 milligram per minute. Oral dose valproate is a very common drug use. For 500 to 600 milligram per day, maybe increased to even up to 1000 milligram 1500 milligram per day, maybe more. but the complications are there like weight gain, hepatotoxicity, teratogenicity are the common complications I have already discussed.